Ghosh.
Respected Chairperson, Sir, Madam, dignitaries of the dais, after the persistence request from Mr. Mitro, I have written down a paper on early intervention of infants with developmental delay with emphasis on cerebral palsy. This is the paper I have written from my own experience, and I would like to have questions from you to clarify further if there is any improvement, any chance, any scope for further improvement. American Academy of Cerebral Palsy and Developmental Medicine describes cerebral palsy, a heterogeneous group of non-progressive motor and posture disorders of cerebral or cerebellar origin that typically manifest early in life. The primary impairment involves significant deficits in motor planning and control. Although the definition does not imply etiology, the causes include cerebral malformations, metabolic and genetic causes, infection both intrauterine and extrauterine, stroke, hypoxic ischemia, and trauma. The damage is non-progressive, and the motor function that is affected results from the part of the brain that is involved. Although the damage is non-progressive, clinical manifestations often change over time as the functional expression of the underlying brain is modified by normal brain development and maturation. In contrast with popular perception, large clinical epidemiologic and longitudinal studies indicate that perinatal asphyxia is an important but relatively minor cause. Estimates range from a low of 3% to a high of 21%. In most cases, the events leading to cerebral palsy occur in the fetus before the onset of labor or in the newborn after delivery. The incidence of cerebral palsy is in the range of 1.5 to 2.5 per 1,000 live births. While exact figures are unavailable in India, it can be safely estimated that the cumulative figures for living population at any given point may be staggering. Although cerebral palsy is essentially a movement disorder, it may be coexisting with associated problems such as visual impairment, auditory and speech defects, cognitive deficits, and seizure disorder. Orthopedic deformities such as contractures and deformities of the limbs, spinal deformities such as kyphoscoliosis, dental problems, gastroesophageal reflux may be found in children with severe motor impairment. What is the role of central nervous system in motor development? In the animal kingdom, it is probably the human babies who require the much needed care to rear them till the time they learn to care for themselves. The obvious reason for this prolonged care and protection is the time required for maturation of the human nervous system, of which the brain and spinal cord are the essential components. The essential components of growth of neurons come from mother's milk, and the functions of neurons develop through continuous interactions with people and the environment around the child. Movements, which are also known as motor behavior, begin around 10 to 12 weeks of gestation in mother's womb, when a baby floats, cruises, or kicks in the amniotic fluid. Movements of different parts of the body actually send the sensation of movement to the brain through spinal cord, and the more the child moves after birth, the faster is the pace of learning of more complex movements. Our eyes, ears, nose, skin, tongue analogize the windows and doors of a room through which the light and air enters to stimulate us. Such organs act as media through which information floods our brain, and the movements function as interface to each system to appropriately respond to the stimuli. In fact, the first 2 years of development, as described in Piaget's theory as sensorimotor development, is spent in acquiring all kinds of sensations through movements and locomotion. Although the formation of brain and spinal cord is formed within the 4 weeks of gestation, the connections between the neurons, which is also known as synaptogenesis, continue to take place even after birth. The process of arborization of the neurons keeps continuing with the formation of new connections between the neurons with those movements that are most practiced by the child, and simultaneously those connections are pruned which are not practiced or appeared irrelevant by the child. Thus, from the gross motor movements such as kicking of legs and throwing of arms in lying positions, lifting of head and body, required to move about the floor, develop into sitting and standing before the emergence of use of hands for holding toys and objects. Should we consider a child's development is only certain vertical steps of a number of milestones? Well, development of a child is often projected as major achievements along her development trajectory, also called milestones. Every milestone is the cumulative success in terms of execution of smaller tasks in the previous stage of development that lead to the achievement of a function or an ability to perform the tasks considered appropriate for age. Development is thus ever evolving, ever growing, and ever challenging. It cuts across the boundaries of different domains such as vision, hearing, cognition, gross and fine motor, and overlaps as development progresses. What we understand as milestones in one domain of development is actually contributions from other developmental domains as well. For example, a child's ability to chew food at 9 months of age, which is an important milestone in oral motor development, is the summation of motor milestones such as head control by 3 months, sitting without arm support by 9 months, holding and voluntarily retaining an object in hands by 4 months, eye contact and visual tracking by 3 months, which is a significant contribution of visual ability, distinguishing food from a toy, requiring understanding or cognition. So development requires uninterrupted formation and growth of the nervous system and positive feedback for the nurturing environment that is conducive for learning that continues through the entire lifespan. What happens when there is a deviation of natural motor development? I prefer to use the word natural motor development because many people use the word normal development, but in normal development there is so much of variation, so it's better to use the word natural development. Due to some environmental and genetic aberrations, motor development of a child may be adversely affected. A delay in motor development is usually manifested as the child's inability to reach or achieve a milestone expected of her age in comparison to other children of her age. In other words, a child's ability to perform the age-appropriate tasks is either stalled or slowed down well beyond her usual age of achievement. An interesting observation of natural development of children indicates that a child learns more and more complex tasks on the basis of overflowing of sensory information across different sensory systems and equally maturing neuromuscular and skeletal systems. For example, a 6-month-old child rolls over to get a toy car kept at a distance and then mounts it. But the same child at 1 year will push the toy car on its wheels. With further maturation of vision, cognition, and physical abilities, the child will try to let the car down slopes and let it crash against the wall or into another car on the floor. He also shouts in acclamation with the word accident. This is only possible with the evolving physical abilities and ever unfolding cognitive and communication skills the child aptly combines during play. Therefore, any delay in a domain of development may delay or conceal development in other areas of development. Delay in sitting, standing, or walking is often noticed in children with visual impairment. Ability to walk is not only a physical skill, but involves a child's lower limbs, but also calls for a perfect blend of visual, proprioceptive, vestibular, tactile, kinesthetic, and other sensory inputs. Delay becomes disability when a child either never achieves a milestone in an isolated domain of development or his or her multiple areas of development become affected simultaneously. For example, a delay in cognitive development can cause difficulties in planning and successful execution of movement, affect motor abilities such as sitting or standing, and the child may have difficulties in using his arms required for learning daily living skills or pursuing academics, although he does not have neuromuscular dysfunction or skeletal deformities per se. Simultaneously, His communication and socialization may also be affected due to cognitive impairment, the skills which would otherwise facilitate his participation in the society. For this child, independent living will require adult supervision. A child with transient motor delay without any cognitive deficit may eventually catch up. How to detect early indicators of neuromotor impairment? Although the chances of developing neuromotor impairment and other developmental disabilities are more likely in sick newborns who are treated in the sick newborn care units, ideally every child should be screened to detect visual and hearing deficits alongside quality of movements and muscle tone. Such comprehensive screening systems demand time and professional expertise of various disciplines such as pediatricians, optometrists, ophthalmologists, audiologists, and speech and language pathologists, physiotherapists, and occupational therapists, psychologists. Screening helps to detect minor deviations in different domains of development, which then necessitate a detailed assessment. Assessment should lead to confirmation of the diagnosis of the condition, and a comprehensive management of the infant is required to enable the child to learn. There are many validated screening and assessment tools available which can be appropriately employed with prior training of the caring professionals. Why early? There is enough proven scientific evidence that proposes the rate of new neuronal connections remains very high within the 2 years of age, although it continues at a slower rate throughout life. The same can be corroborated by the fact that the head size, the volume of the brain of an infant increases by almost 12 centimeters by the end of 1 year. New synaptic connections are made and strengthened as the child keeps learning new facts through all her sensory organs with the help of her body movements. The first 2 years of age is therefore extremely critical, even in conditions where damage to the neurons occur during or before birth. Stimulation through interaction, play, exposure to the sounds, light, and various textures may help to create new connections amongst the undamaged neurons. The process of rewiring and reorganization of the brain is known as neuroplasticity of the central nervous system. If a systematic and planned intervention can be employed, after the delay in motor or sensory development is found, one can expect a better outcome as neuroplasticity occurs naturally in abundance within the first 2 years of life. In children with neuromotor impairment, where tonal abnormality is the cornerstone of movement dysfunction, early motor intervention may help in normalizing abnormal tone and thereby enable the child to achieve postural stability to improve his or her functional skills. Extensive and regular intervention through developmentally supportive positioning right from the SNCUs and facilitative movements provide an opportunity to facilitate motor development. For example, an infant with asymmetrical posture with head turned to one side will not be able to bring her hands to mouth. If she is left in that asymmetrical posture, the child may develop tightness in the neck and shoulder girdle muscles, and most importantly, the brain would have had a distorted body schema. Supine posture experiences, a naturally developing child by bringing his hands in midline in a stable symmetrical supine posture experiences the movements and position of the arms and hands in his body. Infants put their fingers into mouths to suck, but by sucking the child learns to manipulate the fingers in the mouth and conversely learns to manipulate the tongue. So by doing such mouthing activities, the child prepares to eat independently. If with the help of a cushion, the child's head can be kept in midline and the shoulders are kept protracted with the help of 2 rolled towels placed under the shoulders, the child will be able to bring his hands together in the midline of the body and put fingers into mouth. The child will now get an opportunity to see the hands in a corrected symmetrical position. The brain will now experience the symmetrical posture that facilitates eye contact with the mother and the hands to midline, but also prepares the child for eating and drinking. Mother and child interaction will be immensely facilitated. That further strengthens the emotional bond between them and lays down the basis for future social interaction. The mother will enjoy the pleasure of rearing her child and joy and happiness replaces her anxiety. So by positioning the child in a stable symmetrical posture, natural motor activities can be facilitated and simultaneously opportunities created in social interaction, enhanced communication skills, eating and drinking, and above all, provide the child with correct body schema, which has tremendous perceptual significance, is the basis for learning of any skills. The role of a pediatric physiotherapist. A pediatric physiotherapist is a trained healthcare professional with adequate knowledge in child development and movement disorders caused by damage to the brain. During regular visits in the SNCUs, it is the duty of the physiotherapist to promote developmentally supportive positioning to every infant and provide odomotor stimulation to facilitate breastfeeding. Their responsibility also includes training the mothers in terms of correct way of carrying, handling, and interaction to facilitate carryover of intervention at home. The physiotherapist should work with the neonatologist and the nurses in the SNCUs to apprise them of the condition of the infants requiring chest physiotherapy. The physiotherapist should be able to detect posture and movement abnormalities while screening the infants at discharge from the sick newborn care units and employ motor intervention measures. Children with florid neuromotor dysfunction require a thorough assessment of the tonal abnormality that causes postural asymmetry and movement restrictions to accomplish functional activities. While working with the children and their families, the physiotherapist should formulate management programs for the children, keeping in mind their financial and time constraints. Appropriate furniture and aids and appliances should be prescribed by the physiotherapist, and their functionality must be reviewed at every 3 or 6 months intervals. A close liaison with the family members with regards to intervention is the key to successfully implementing the management program. Importance of parents' training. Guiding and training the parents in home management is extremely important for carryover of treatment at home. A child is only handled by a physiotherapist in the clinic for a limited period of time. Motor intervention should ideally be carried over into activities of daily life, that is, while the child is dressed and undressed, during play, while being fed. The therapist must share their knowledge and skills on how to handle the child during these daily activities. Treatment and management program should not just a set of exercises, quote unquote, to be done routinely for a certain period of time regularly. Rather, a child's movements and skills should be encouraged in every activity the parents do with their child. The therapist should employ their skills to address more specific issues related to abnormal tone and qualities of patterns of movements, and can demonstrate to the parents simple handling techniques that inhibit abnormal tone, simultaneously facilitate motor abilities and function during activities such as carrying, sitting, playing, and bathing. There is copious scientific evidence now available that indicates the repeated bombardment of the central nervous system with correct sensations of movements and learning opportunities is required to create new neuronal connections and strengthen those neuronal pathways in the central nervous system which have suffered an insult during the developmental period. The plastic changes in the nervous system will only be effective if the child's brain receives repeated neural messages through the right stimuli in various care activities throughout the day. Therefore, parents' understanding about the child's management and a positive developmental outcome is intimately related. What should be the integrated approach of management? It is the surveillance, screening, early detection, and then assessment and immediate intervention. Infants born with various risk factors related to low birth weight, prematurity, and perinatal asphyxia are at risk of developing developmental delay or disability, including cerebral palsy. Apart from biological risks, environmental deprivations in the SNCUs and NICUs are also considered as risk factors that may delay age-appropriate development, and in some cases, development may be totally deviated from the natural course. Infants with a history of neonatal complications that may cause delay in motor development should be observed regularly in the intensive care units for any emerging tonal abnormality that may be manifested in postural asymmetry, feeding difficulties, and/or disturbed sleep-wake pattern. Surveillance of infants with at-risk factors call for screening to identify any delay or disorder. Screening is a process that helps to identify infants who might have delays in development and allows an appropriate referral. It should be done as a routine part of a neonatal follow-up program. Screening tools are intended to identify children who might have developmental delays and to make an appropriate referral. Screening tools may only provide an indication of developmental delays but cannot help in diagnosis. A positive screening outcome should be followed by a thorough assessment. Physiotherapy intervention for young children with neuromotor dysfunction, basically early intervention aims to promote postural alignment, normalize abnormal postural tone, facilitate a variety of pattern movements on the background of a stable posture, improve balance reactions, and improve function. The advantages of motor intervention: number one, abnormal sensory experience of movements can be modified early because the baby does not yet show much abnormality and therefore has little experience of abnormal movements. Massive myelination and synaptic connections occur abundantly during the first 2 years of life, and these may be fully utilized to form correct patterns of movements instead of abnormal patterns in the central nervous system. Through handling and caregiving, correct posture can be maintained and variety of movement patterns can be encouraged by the parents throughout the day. This ensures carryover of treatment. Normal posture and movements mutually strengthen development of other systems such as vision and hearing, which immensely influence cognitive development. Early learning reciprocally enriches motor development and vice versa. To conclude, I must refer to a Sanskrit sentence, Suhasya Sighram, which means initiate a good and auspicious work very early. We should always intervene and see that